Welcome. Today, we are diving into what is honestly a fascinating medical detective story. We're going to walk through a real world clinical case study of a pretty nasty sports injury. And what's really cool here is we're going to see exactly how specialists blend Western objective findings with traditional Chinese medicine, or TCM, to crack these complex clinical puzzles and get athletes safely back out on the field. So let's jump right in.
Picture this. An athlete walks into your clinic in absolute agony. The clock is immediately ticking. You've got just minutes to figure something out. How do you differentiate between a standard, run-of-the-mill muscle spasm and a potentially career-threatening nerve injury? Making the wrong call here could literally lead to permanent damage. Let's piece together exactly how clinical specialists solve this kind of high-stakes puzzle, step by step.
Okay, let's set the scene. 2 days ago, our patient, who is an active student rugby player, suffered a massive, high-impact collision out on the pitch. He took a really hard bump from another player, directly injuring his left shoulder and neck. Now he's presenting with this throbbing pain on the left side of his neck and shoulder, and he's rating it a solid 5 out of 10. But honestly, it's not just the pain. He is dealing with severe stiffness and this really deep, sore sensation that flares up big time the second he tries to change positions or just turn his head.
All right, part 1, the initial neck and shoulder assessment.
So, using this dual diagnostic approach, we start gathering our initial clues. On the Western medicine side, we've got our objective, active range of motion findings. Cervical flexion and extension are totally locked up, restricted to just 40 degrees with pain right at the end range. And his left shoulder abduction, it essentially hits a brick wall at 90 degrees. Then, looking at the TCM side, his pulse is wiry and fast, and his tongue is red with a yellow fur coat. When you put all of that together, those restricted motions pair perfectly with the TCM signs to paint a very clear picture of acute, localized trauma.
Now, the absolutely crucial part here is understanding the pathology behind those TCM signs. The diagnosis is qi and blood stagnation with localized heat, specifically in the Taiyang and Shaoyang channels. Think of it like a massive pileup on the highway. That rugby collision created a literal physiological roadblock in his soft tissues. Because the blood and energy, the qi, can't circulate properly, local pressure just builds and builds. This causes inflammatory heat and tissue swelling. We did a quick system check, and there's no systemic fever or headache, so we know this heat is entirely localized right at the collision site.
Moving right along to part 2, stagnation, heat, and acupuncture.
So, what's the game plan? Here is the 3-step approach we use to tackle both the energetic roadblocks and the structural strain. Step 1 utilizes local acupuncture points. We're talking GB20, LI15, SI11, and Ashi pain points, using a reducing method. Mechanically, this stimulates local blood flow to actively flush out that inflammatory heat and relieve the ischemia in the muscle fibers. Step 2 brings in a distal point down the arm, SI3. This acts kind of like a release valve, opening up the Taiyang channel to relax the neck from afar. And finally, step 3, we apply kinesiology tape to give him some much-needed structural support and promote lymphatic drainage. This whole protocol is specifically designed to soothe blood flow and clear out that heat. We're looking at a prescription of 3 sessions a week for 2 weeks, paired with some very gentle stretching, but honestly, the most vital part of all of this, strict rest. No contact sports, no heavy lifting, no sudden twists. That area absolutely has to be protected from any further microtrauma so the inflammatory heat can actually fully subside.
Which brings us to part 3, symptom shift and neurological screening. All right, the patient comes back in for session 2. The daytime neck stiffness is actually eased up a bit, but then a new, pretty alarming symptom pops up. The pain is now radiating from his left neck and shoulder all the way down into his upper arm and scapula. He describes it as this deep soreness and a really tight sensation that gets way, way worse at night. So what on earth is going on here? This is a major clinical plot twist. When we compare the data from session 1 to session 2, his joint mobility is, technically speaking, improving. Cervical flexion and extension increased to 45 and 50 degrees, and shoulder abduction bumped up to 100 degrees. So the structural lockdown is easing. But, and this is a big but, hitting those new end ranges completely triggers that shooting, radiating pain. This mismatch, where mobility is getting better but there's a worsening, radiating night pain, demands urgent investigation.
Let's dive into part 4, nerve root versus myofascial.
We are essentially at a clinical crossroads here, having to differentiate between two wildly different paths. Is this nerve root compression? If it is, we'd expect a weak grip, numbness, and a positive Sperling's test, which is where compressing the spine literally shoots pain straight down the arm. Or is it somatic referred pain coming from some really angry muscle tissue? To figure it out, we test his dermatomes and myotomes. Think of these as skin sensation maps and strength tests for the body's internal wiring. We are quite literally checking the electrical cables running down this player's arm.
So, the moment of truth. The results? He passed the neurological screenings with flying colors. Light touch sensation all across the C5 to T1 dermatomes was perfectly intact. His grip strength and myotomes were a rock-solid 5 out of 5 bilaterally. Deep tendon reflexes were totally normal, and crucially, the Sperling's test was negative. This is fantastic news because it proves we are not dealing with a pinched nerve root. Instead, this is a nasty somatic referred pain pattern coming from acute spasming trigger points in the scapula and neck.
Moving into part 5, Tuina contraindications and red flags.
Because we're dealing with an acute, radiating trigger point referral, the whole treatment plan pivots. We bring in a TDP infrared lamp for 20 minutes to jumpstart tissue repair, and we reapply the K-tape. But I want you to notice the primary intervention here, gentle, superficial Tuina massage. This is used to gradually desensitize that overactive nervous system and ease up those nighttime spasms. But listen, this comes with a massive, non-negotiable clinical rule. You must strictly avoid deep pressure directly over that acute radiating pathway. If you press deeply into a highly sensitized myofascial pathway, you will only aggravate the tissue and cause a massive pain flare-up. Now, because this situation is actively evolving, educating the patient on home monitoring is absolutely vital. We have to clearly lay out the neurological red flags that demand an immediate emergency assessment. We're talking about progressive arm weakness, any numbness, a sudden loss of hand grip strength, or severe night pain that completely prevents sleep. Monitoring these flags is our safety net. It ensures we don't accidentally send a player back out onto the field who might actually be developing a delayed neurological complication.
And that leads us directly into our golden rule for rehabilitation. Continue resting from heavy exercise and contact sports until you are fully medically cleared. Sure, the muscles might feel a bit looser and maybe the neck can turn a bit further, but that radiating pain is a massive warning sign telling us the myofascial network is still on high alert. Going back to the pitch is only safe once full range of motion is restored without triggering any radiating pain whatsoever. Patience right here is just a non-negotiable part of the prescription.
So I'll leave you with this thought. Pain is your body's alarm system. Are you actually listening to what it's trying to tell you before you rush back to the pitch? As we saw today, a slight increase in mobility does not mean the injury is magically healed, especially if the pain shifts from a localized ache to a radiating warning signal. Learning to really read those signals, map them out correctly, and respect the natural healing timeline, that is what ultimately saves an athlete's career.